bin. I like to do that all at the end. I think it's safer. I put my spent files at the side of my sponge, so I know all of the files that are at the side are the ones I'm not using, and all the ones that are sitting on the top are the ones I am using. I don't like to use an endo ring. I just think it gets in the way. So, hello, welcome to this week's clinical case. This is going to be a short, sweet, full root canal case, as it is every Friday. But usually I don't put these sort of short cases up, but I think today's one is a really, really interesting case because what happened in this instance is that when we were using our shaping files, a very, very subtle sign on the shaping file indicated that it was about to fracture. So I thought this would be a really, really good learning experience for everybody. So it's a great little case. But before we get into the case itself, I just want to say that when we look at the metrics, we can see that over 40 to 50% of people who watch these videos are not subscribers. So if you could just do me one really, really small favor, it's free, it's easy, and that's just to hit subscribe button. It spurs me on to do more with the channel, and I promise if you press that subscribe button, the videos are going to get better and better each week. And if you want to bring your support even further, then we've got a membership program. The membership program has early access to content. So usually I run about 2 weeks ahead with our with the videos that we post every Friday. So you can get early access to that. And we also now have exclusive content. We've got a fantastic hour-long root canal access video. So if you want to bring the support even further, join the membership program. Let's get on with the case. Okay, so we'll get straight into the case here. This is another external referral from another referring dentist. It's a lower left 5. The tooth itself has got severe decay, and the tooth was exhibiting symptoms of irreversible pulpitis. And the patient obviously was given a full consult, given all risks and benefits, and she decided to go ahead with root canal treatment. And in my opinion, I think this is a pretty nice little case. When I look at this tooth, I'm thinking it's looking long. Okay, so that's always in the back of my mind. And we pick up the video here with me just removing the temporary dressing. So I believe the referring dentist has sort of shored up this tooth, put a composite filling in, and dressed it with cotton wool. And we can see here that the pulp is vital. So this is sometimes a bit of a concern to newly qualified dentists, is what to do in these types of cases. Well, the problem with doing like a sort of a pulp cap or a pulpotomy is that the patient was exhibiting symptoms of real irreversible pulpitis. So if obviously you're accessing a tooth and you can see that the pulp is vital, but the patient's not having any obvious symptoms, and we can see the tooth is restorable, then maybe there's a suggestion you could do some sort of pulp cap. But in this case, the patient was having severe pain on biting, really, really sore, aching pain for lasting more than 10 minutes. So in this case, although the tooth looks vital, it needs to have a root canal done. So at the first instance, I'm going to try and negotiate with my size 10K file. I'm trying to just sort of poke that size 10K file into the little hole there. Obviously, with teeth that are vital, sometimes it can be a bit difficult to numb up. That's something I see all the time. And then I'm just going to use my master apical file. In this case, it's a HyFlex 25 variable, just to open up the kind of canal space. And once we give it a little bit of irrigation, we can see here now that the orifice is a bit more open. Maybe off center, maybe I'm thinking about there's maybe another canal. But in the meantime, what I'm going to do is just going to shape this canal and just sort of review the situation. And the patient had quite a difficult mouth opening, so it was difficult for me to get my size 10K file in place here. But I can see that the canal orifice is really, really big, so it can be a bit frustrating. So once I have put my size 10K file into place, I'm going to just, the canal space is really, really wide, so I'm going to go straight for my apex locator. And in this case, I'm struggling slightly to get to length on this. Not because I can't negotiate very well with this hand file. The hand file isn't getting any resistance. I feel like the hand file is actually not long enough. So in this case, what I'm going to have to do is I'm going to get a size 31 hand file just to give me a little bit extra file shank so I can clip my apex locator on, and it's found that when it gets 0 on the apex locator, it's found to be 25.5 millimeters. So this means I don't need to get any sort of extra special long files out. I can just use my glide path file here. Although it's important to mention that using files all the way up to their shank is a little bit risky business, so it's something to have a little think about. And when I pull this file out, what I notice is I'm always looking at the end of the file as it's coming out, mainly to see if the tip's still on it. I think it's just one of those things that I have I don't know, some sort of OCD about, but I always check the tip. But as I pulled the file out, I glanced, and just in the corner of my eye, I noticed that the flutes, or the sort of winding of the file, weren't quite what I'd like. So when I looked at the file, underneath the microscope, I can see that it's starting to unwind. And what I've done here is I've taken out a fresh size 10 glide path file, and you can see that the winding is much more tight on the top file compared to the bottom. So the best thing for us to do here is just to take that file and place it out the way. And what I don't tend to do is I don't tend to chuck it straight into the sharps bin. I like to do that all at the end. I think it's safer. I put my spent files at the side of my sponge, so I know all of the files that are at the side are the ones I'm not using, and all the ones that are sitting on the top are the ones I am using. I don't like to use an endo ring. I just think it gets in the way. So once we've sort of negotiated to length with the glide path file, we're ready for our irrigation and our final shaping. Again, I am going to be shaping 0.5 millimeters away from the 0 reading. So in this case, the size 25 variable is going to be shaping right up to the hub on this file. Again, just need to be super careful, and we're just going to do some nice little pecks, a little bit of recapitulation, a little bit of irrigation. Just be really careful. So I've noticed here that when I pull this this file out, we can see there's a significant amount of debris on this file, and what you need to be understanding is that you need to remove debris, because what it can cause is severe friction on the file, and then it can cause file fracture. So what I tend to do is I like to just use my sponge to remove the debris, but what you've got to be really careful of is that you're not pushing this file too far and you cause a sharps injury. So just to be really super mindful of that. And I think it's one of the reasons why I don't like using an endo ring. I like to have the sort of control there. And then once we've removed the debris, again, it's just the same thing. We're just going to do a little bit of pecking with our rotary file, a little bit of recapitulation. What I mean by recapitulation is I'm getting a hand file down there just to make sure the canal is still painted open, and lots of irrigation. We're then ready for our cone fit radiograph. Again, I'm just going to measure the cone here at 25. I like to crimp it at this point, and then I make like a little bit of a kink. And I know that this is the point now when we put the GP cone into length, that's going to reach the point where our measuring point is on the tooth. In this case, it's the buccal cusp, and it goes nicely to length. Doing a little bit of tug back to see if we've got sort of a nice sort of fit at the apical end. And when we look at the cone fit radiograph, it looks fantastic. So we know that we've got this lovely cone all the way to length. It's just a little bit short of the radiographic apex, indicating that we've sort of confined to the apical constriction. And then we're ready for our final irrigation protocol. It's always the same: sodium hypochlorite. I'm going to activate it with an ultrasonic activator. Then we're going to use 17% EDTA, activate, and then we're going to use sodium hypochlorite and activate it. And I'm going to use as much of each of the fluids until it runs clear. So my first rinse is going to be sodium hypochlorite, and I'm going to activate it until it runs clear, etc. Once we've irrigated, we're going to dry with some paper points, and we can see here that the canal orifice is right down the center of this tooth, so I'm not worried about an extra canal. I'm going to use these high flex paper points. In this case, I'm going to push it to length, and then we're going to have a little look at the end, a little bit concertina, but we're happy with that. I'm just going to keep doing that until it is nice and dry. So it's really important to dry the canal with a bioceramic. Sometimes that can be washed away if it's still wet. And in this case, what I'm concerned about is getting enough of the bioceramic to the working length. So I'm going to measure the visco tip at about 19 millimeters. So I'm going to be about maybe 19, 20 millimeters. It's going to be a couple of millimeters away from the apical end. And then I'm just going to very, very gently just backfill the canal space with this bioceramic. But what I'm going to not fill it completely with bioceramic because I don't want to overfill it. And then I am going to get a hand file here, and I'm going to introduce the hand file with the bioceramic in the canal, so it sort of pushes it all to length, and it gets rid of any sort of vapor lock. So once we place this GP cone to length, it's not going to the sealer isn't going to stop the GP point from reaching all the way to the end of the tooth. And what we do is we just to be really, really gentle as we push in the GP cone to length. We're watching for that sort of kink to hit the mark where we know is our reproducible point. And then I'm going to remove the excess with a heated plugger. And rather than pushing my heated plugger all the way down to the sort of coronal orifice, I'm just going to remove a little bit of excess first, because when we go straight for the coronal orifice, sometimes you pull the whole GP cone out. So I just like to remove a little bit first, and then compact it down a little bit, see what we've got left, and just remove more and more of the excess. And this is important because obviously what we want to do is we want to just make sure the GP is just slightly below the orifice level. So when we come to fill this, it's going to be nice and sealed. And sometimes this can be a little bit tricky, especially if you've got quite a narrow opening. So a lot of the times when you've got a molar, it's going to have quite a large access cavity, and you can sort of shear off the GP quite easily. But in this case, because it's a narrow opening, you're kind of removing this GP in little tiny bits, which can be frustrating. And then the final thing we're going to do is we're going to push it down with our Mach 2 plugger. And don't be shy. Give it a good old push, okay? And once we feel like we've got to the end, and we've removed enough of the excess, I'm going to pick up my ultrasonic scaler, and we're going to just clean the access cavity. This is the great thing about bioceramics; they just wash away from the access cavity. And once we've cleaned the access cavity, we're going to just have a little bit of assessment to see if we've removed all of the bioceramic, and we can see here that we have. It all looks really nice and well compacted. And then I always give it a little extra push just to make sure we think we've got everything down. Because sometimes when it's a bit of a mess down there, and you feel like you've compacted it enough, once you sort of give it all a bit of a clean out and give it a further compaction, you've got a bit more vision to see and compact it a little bit better. And then we're finally ready for our final obturation. In this case, I'm using Scotchbond, which is a self-etch system, and we're going to just air dry it. Again, I'm not a restorative dentist, so my bonding protocols might not be as good as someone else, but in this case, I'm happy to use this. So we're going to make sure it's all nice and dry, and then we're going to light cure it. And then I like to use SDR, which is Smart Dentin Replacements, I think it's called that, I'm not too sure. And then we're just going to backfill it. It's essentially a bulk fill bulk fill flowable composite. And we look at the x-ray, it looks great, looks absolutely beautiful. So it's to length, and we can see that some of the bioceramic has maybe pushed a little bit further apically, so we've sort of we've filled that kind of apical constriction, that sort of complex apical anatomy. And overall, I'm very, very, very happy with this tooth. So if you've taken anything away from today, I think if you're doing root canals, always inspect the end of your instruments, because a lot of the times if they look damaged but they're not fractured, you've still got a second chance just to replace it. Because of course, once you've fractured the end of an instrument, especially to the tip, you know, it's going to be nigh on impossible to remove that piece unless you dislodge it or you bypass it, which again is fraught with danger and difficulty. So prevention is better than cure. And overall, thanks for watching. It's a nice short and sweet video today. Again, please like and subscribe if you haven't. It's a really, really easy way to support the channel. And again, if you want to support the channel even further, you can join our membership program on YouTube. You get early access to content, you get exclusive content, and I will see you in the next video next week. Bye bye.